Hope you like this new format without the PowerPoint presentation, and I'll be discussing a few basic topics in a simple format. Do subscribe and do share these with your colleagues, encourage them to subscribe as well. So today I'll be discussing neonatal jaundice, and you are familiar with the concept of neonatal jaundice, why jaundice happens. There is a playlist on jaundice on my channel. I would refer you to go through that. In short, the newborn baby is born with excess red blood cells, and because the neutral environment is relatively hypoxic. When the baby is born and the oxygen in the environment increases, the baby starts destroying the red blood cells that it doesn't need. One of the byproducts of the red blood cell breakdown, or the heme, which is component of the red blood cell, the hemoglobin breakdown, is a pigment called bilirubin. And bilirubin load is high because of this RBC breakdown. The pathological factors may be there as well. In some cases, you may have an excess load of blood breakdown because there is a cephalometoma or bruising on the skin. You may have dehydration because you need good hydration to eliminate this. Or you may have hemolysis, you may have blood group incompatibilities, either RH incompatibility or ABO group incompatibility, which is increasing the red blood cell lysis and the bilirubin production. The production is on one side and the elimination is on the other side. The liver is the main organ which receives the bilirubin from the blood, conjugates it, and the conjugated bilirubin is excreted through the bile into the stool. Part of it gets recirculated as well. So if the liver is immature, as it is normally in the first week to 10 days, and you face excess load, you get the physiologic jaundice. A premature baby has a higher risk of jaundice because the liver tends to be more immature. It takes longer for the liver to start coping with the load. In a breastfeeding baby, the breast milk sometimes has a factor called bilirubin glucuronidase, which can uncouple the conjugated bilirubin into the indirect bilirubin again, which can get recirculated from the tummy. And this leads to prolonged jaundice in certain babies. The acute rise in bilirubin that happens with hemolysis overwhelms the body's ability, and normally the bilirubin is an indirect form when it is circulating, and it's bound to albumin, so it doesn't cross the blood-brain barrier. But when the production is at a fast rate, it doesn't meet the binding ability of the albumin, and there is free bilirubin, and this free bilirubin can cross the blood-brain barrier. So the blood-brain barrier exists to prevent toxic effects of certain chemicals which may enter the brain. Without this barrier, same applies to infections as well. So when the blood-brain barrier is overwhelmed, the free bilirubin can enter the brain, and that is the danger. That is the reason we monitor for the jaundice, and we have to treat the jaundice before it reaches a dangerous level. When it enters the blood-brain barrier and settles down in the brain, the pigment may damage the portion of the brain. We have a certain form of bilirubin-induced neurological damage, bind it's called, and in olden days it was called kernicterus. So the baby may present with lethargy, poor feeding, irritability, opistotonic posturing, excess crying, and fits may happen. Ultimately the baby becomes comatose and they may die from that, or when they recover they have sequelae, which is the choriothetoid form of cerebral palsy. So in short, though bilirubin metabolism goes through these transitional changes and physiologic jaundice is seen in more than 60% of the term babies and almost all the premature babies, the reason we monitor for bilirubin load and the levels in the first week to 10 days of life is for the risk of bilirubin-induced neurological injury or damage. Hearing loss is also an effect of a very high bilirubin level. So every unit should have a protocol when they assess the bilirubin. So we screen for hyperbilirubinemia. The American Academy of Pediatrics and various other bodies have come up with guidelines. I would refer you to the two videos I have on the American Academy of Pediatrics recent update on jaundice. We do have tools like the Billy tool, which again I've explained in a video on how to use it. So go through these videos to get a better idea. But in short, we need to screen the baby for jaundice. If there is any risk factor like blood group incompatibility, or you notice the bilirubin is high in the early stages, we need to monitor more closely. There are certain features which suggest that the jaundice is not exactly physiologic. We need to be alert. So it includes a jaundice which is high in the first 24 hours. We have the nomograms which you can plot on. So previously we used to say any visible jaundice in the first 24 hours is significant, but with more and more delayed cord clamping, we do see a few babies with visible jaundice early on. So follow the trend. Even if there is slight jaundice, if there is no risk factor, baby is otherwise well, and the nomogram, monitor it every 6 hours or so, and if the nomogram suggests the rate of rise is not high, it's okay. It could be because of the higher hemoglobin load that the baby gets from the delayed cord clamping. You can review my videos on delayed cord clamping as well. It's very important to do delayed cord clamping. The jaundice risk is not significant because of that, and actually this extra hemoglobin is going to help the baby have more hemodynamic stability. The baby gets immune factors from the mother from this extra blood as well, and the risk of iron deficiency is reduced as they grow as well. So once you screen for the jaundice and you monitor the levels, we need to make plans according to that. Supporting the feeding is very important, because delayed lactogenesis can be one factor which aggravates the jaundice in breastfeeding baby. Start early. You can consider antenatal expression if there is a risk, like it's a primary gravida mother, gestational diabetes, twins. So you can start from 36 weeks to express breast milk. Have a lactation consultant review the mother in the first 24 hours. So it's better to intervene early. Remember that if the latch is not good, intervene early, stimulate the mother to express the breast milk so that the milk is emptied and produces more, and so on. So feeding is important for jaundice, and when we screen, if you notice there is a risk factor, you screen more closely, more often. Transcutaneous bilirubin is a good way to screen, because you don't need to prick the baby. If there is any concern, if the bilirubin is rising or it is approaching treatment level, you always have to do a serum bilirubin. Most of the units have micro samples. You can do capillary samples for the bilirubin, and we get the result almost immediately from the blood gas machine, for example. But if you have treatment levels exceeded or it's approaching exchange levels, we have to send it to the lab for confirmation. The cutoff for exchange transfusion is variable depending on the age of the baby, and this is because the trend of the bilirubin suggests pathological jaundice. If the rate of rise is very fast, it's more likely pathologic. And I mentioned that hemolytic jaundice has a higher risk of brain injury, because the products of hemolysis also bind to albumin, so there is more competition with albumin binding, so you have a higher chance of free bilirubin at a lower level than what you would have otherwise. So it's very important to be aggressive when you think the jaundice is hemolytic. If the baby has asphyxia, if the baby has sepsis, hypoglycemia, acidosis, any of these that can affect the blood-brain barrier, the risk of the bilirubin crossing the blood-brain barrier is significant. Again, we need to be careful with these cases.